Good afternoon, everybody. Thank you for joining us today for our third Data to Drive Decisions webinar. And this topic today is on improving population health in Colorado. We're excited to have you all join us today. I'm pleased to be joined by several of my co-workers today. I'm Carrie Frank. I'm the Vice President of Communication and Marketing. And Maria de Jesus Diaz Perez is also joining us today. She's the Director of Research and Performance Measurement. We also have Tim Janader, and he is a healthcare data analyst, as well as Emma Anderson, also a healthcare reporting analyst. So we have a fun crew here today. Just a few housekeeping items before we get into the meat of our presentation. We do have you all muted right now, but we would love to hear from you. So please ask questions in the chat box. We are recording this webinar, and they will be the slides and the link to the recording will be available on our website on the events resource page at civic.org within the next few weeks. The agenda today, we're going to go over Civic quickly and the APCD just for any of you who are joining us for the first time. We do have our main meat of our topic today is improving population health in Colorado. We have two analyses that we're going to show you. One is a community dashboard, which is very exciting. We rolled that out last year for the first time, and then low value care, which is also a very recent analysis that we did within the last year. And we'll have some time for Q&A, and then we'll talk about what future topics we're going to bring to you on this webinar series. So just really quickly about Civic. We are a mission organization, mission driven, we're nonprofit, we're independent and objective. And everything that we do is to support advancing the triple aim of better health, better care, and lower costs. And we do that by empowering individuals, communities, and organizations throughout not only Colorado, but beyond and across the nation. We also provide support services and programmatic services as well. We serve a wide variety of stakeholders, and the most important we always think of is the consumer right there in the middle. But everything that we do to support the other stakeholders ultimately impacts the lives of Coloradans. So we work with hospitals, provider groups and clinicians, government agencies and state agencies, employer groups and purchasing alliances, nonprofit organizations, the payer community and health plans, as well as researchers. Just a quick history of the all payer claims database in Colorado, which is the source of the data that we use that we'll show you today. In 2008, it was a recommendation to develop the APCD by the Blue Ribbon Commission for Healthcare Reform. After that recommendation went into place, legislation was written, and in 2010, the APCD became legislatively mandated. In that same year, we were named the administrator of the Colorado All Payer Claims Database by the state's Medicaid department, which we call HCBUF. In 2012, we operationalized the APCD. We developed the website with public data for the first time, and we began creating custom request process and providing data on a custom basis. Since then, since 2013, we've made a lot of enhancements to the database. We've added additional payers. We've added new infrastructure and analytic capability. We transitioned to new data vendors. We have launched new websites and added new public data. And from 2019 to the present, we've been working with the state in a more collaborative way to develop enhanced data tools, analytics, and more public reporting. So what we do with the data, it really is designed to be presented in two different ways. So we provide public APCD data, which you'll see today, all intended to identify opportunities for improvement with communities through interactive reports and publications. And we also have a Shop for Care tool, which enables consumers to shop for healthcare services. On the other side of what we do, we provide data on a custom basis, and that is licensed data that you can access through the custom report process, which either can be standard data sets and reports or custom data sets and reports. Just a little background on this webinar series. The purpose is really to highlight available data that we have and the capabilities so that everyone is aware of this amazing resource that is available to all of us in the state of Colorado, and also to get feedback from you guys on what we are providing publicly and on a custom basis so that we can make sure that we are providing the most relevant and actionable information to stakeholders in the state and beyond. We do hold these monthly on the third Thursday of every month from 12 to 1 p.m. Mountain Time. And we'll talk about our next webinar at the end. But now I would like to turn it over to Maria. She's going to talk to you about our community dashboard project.
Hello, everyone. Thank you for joining us today. As Carrie mentioned, we would love to share with you today the public report that we have in our website that is called Community Dashboard. The slide that you're seeing is a screenshot of the way the dashboard looks in the website, but we will go take a look in live in a little bit. The community dashboard was created to provide communities across the state of Colorado with information about healthcare performance and different measures of healthcare performance. We are including cost, quality, utilization, and access measures. The purpose of these reports that we provide are, one, to educate consumers and, in this case, stakeholders about healthcare issues and how healthcare is performing across different communities in the state and across time. Inform opportunities of cost savings and improving healthcare, support decision-making within their communities, and most importantly, to track progress that we are making as a state as a whole and also in different counties across the state. As I mentioned before, the measures that we are presenting in this dashboard are cost, stated as dollars per person per year, measures of quality, and we will talk a little bit about more of that when I show you the measures. We talk about access, it's like who's using healthcare in the state and how they are using it, and we'll talk a lot more about that. So we're gonna go to the interactive report now. Can we go there? You can go to civic.org, and if you go to civic.org, you are going to find a menu that is called Get Data. Under Get Data, you can see the item that is called Public Data, and then Focus Areas. Within Focus Areas, the second one from the top is Community Dashboard, and it will take you to the page that we are going to visit today. The data that we're presenting here uses the Colorado All Payers Claim Database, which means that we are using the data submitted by all the payers in the state. It's almost 50 payers that we receive data from. The data in this specific report is using data from 2013 to 2019 and includes, as by definition, only people who have some type of coverage, and that is commercial insurance, with exception of self-insured plans. We are also representing people who are covered by Medicare, whether Advantage or fee-for-service, and people covered by Medicaid. Who is not represented in this report is people who are covered under federal programs like Veterans Programs or the Indian Health Services Program. We do not represent either people who have no payer coverage, like people who are uninsured and paid out of their pockets for their health care. If you want to go down a little, Carrie, this report that you can see has several filters, so you can look at the data whether for all the payers or only for commercial payers, Medicaid, Medicare Advantage. Then you can also choose the year that you want to look at. As I mentioned, this includes data from 2013 to 2019. You can look at the data for one specific county, or you can look at the data for one specific division of insurance region. And if you need to, you might be familiar with division of insurance regions. They are used to set rates in healthcare payment. But you can also learn more about the measures and the definitions in the methodology document that is usually posted on the help me with the right side or the left side? The right side. On the right side of any report that we released in the website, there is a series of resources that are useful to understand the data that is presented. In this case, we have a methodology document where you can look at the detail behind each of the measures that we're going to review here. You can also look at other information like the percent of covered lives that are represented in the APCD, so you have a much better idea of who is being represented in this data. So if we go back to the report, we'll go over the different measures. The first section, as you see, is cost. In this case, as I mentioned, we are representing the dollar amount per person per year. So that means that in 2018, a commercial payer total cost for healthcare was about $5,000, the paid amount. And we are representing paid amounts, which means the amount of money that payers or health plans and patients have to pay for their healthcare. That is an important consideration and distinction. It's not what they agreed to pay, it's what they actually paid for the healthcare. And you have the second column is the statewide. In this case, if you see, we have the selection of Adams County. So you have first the paid amount for commercial payers for 2018 for Adams County. Then we have the statewide paid amount, and then we have a number for the urban counties and a number for the rural counties. This is overall. But then we can also see the payment, the cost of care by service category. We can see that how much was it paid in inpatient services meaning within a hospital, within a hospice, outpatient services in an office clinic or in a hospital outpatient visit also, and professional, meaning any payment that was provided to a doctor or a service provider, like an individual service provider. The other category is pharmacy, and as we know, very important, and that is the number of, or the dollar amount that was paid for prescriptions per person per year. And that is the cost. And if we keep going down to in the report, the next line that you're going to see is called healthcare use. And that is a measure, or two measures, that were derived from the Johns Hopkins ACG software. And this software provides categories of resource use or healthcare resources utilization. The categorization from the software includes 5 categories, but in this report we are only presenting the 2 lowest resource use, and that is the non-users and the healthy users. The non-users are those people who didn't use healthcare services even when they have coverage. Remember, we only have people here who have health plan coverage, but they didn't use it at all. And the number here is a rate per 1,000 people. So about 200 people per 1,000 didn't use their healthcare within a year, within 2018. The next one, healthcare use measure, is healthy users. And that is people who use their healthcare services only for preventive measures, preventive visits, or because they had a cold or they had just a minor situation that required a visit to the doctor. As you can imagine, this is the type of healthcare utilization that everybody would like, right? You only go to the doctor because you're well, to check that you are well, or because you have to solve something minor. Non-users is something that there might be some discussion about that, but in general we would say we wouldn't like to see, because a person who has coverage should be able to at least have a preventive visit per year. And we are presenting here the rate, so we know that at least 200 out of 1,000 are not using their healthcare at all. And we don't know if it is because they really don't need it, or it is because they have other types of barriers like high deductibles or really lack of access, like they cannot get an appointment when they need it, or they cannot leave work because they don't have paid time, or they have to work per hours. We don't know. but we know that about 200 out of 1,000 are not using their healthcare coverage. The next measure is also a utilization measure, and I'm sure you are very familiar with this measure, and it's use of emergency room. This is people who went to the emergency room to get care, to get healthcare, and were not admitted. So they arrived to the emergency room with an issue, and they were not admitted in the inpatient setting. And as you see, it's only 154 out of 1,000 who went to the emergency room among the commercial population in 2018. The next set of measures are measures of access, meaning the percentage of people who use who use healthcare within the year. In this case, it's adults who use any ambulatory service or preventive care within the year, the measurement year or the year past. And the next measure is the children and adolescents who use healthcare. In these specific cases, who visited a primary care provider within the past year. And as you can see, it is 84%, and you might think it's very high, but the truth is that all children and adolescents who have coverage should be visiting their primary care provider at least once a year. The next set of measures is quality of care, and I'm sure everybody has heard about quality of care, but I still want to repeat the definition. The definition from the Institute of Medicine, now National Academy of Medicine, is quality is the degree to which healthcare services for individuals and populations increase the likelihood of desired outcomes and are consistent with current professional knowledge. In this case, we are displaying only three measures of quality. Two of them are considered preventive measures. So these are the procedures that every healthy person in a particular group should have done to detect things in advance and to be able to take care of them. One example is breast cancer screening, and that represents the percentage of women between 50 and 74 years old who had a mammogram within the 12 months or 24 months past before. The next one is cervical cancer screening, or what everybody knows as PAPS, and that is the percentage of women between 21 and 64 who had appropriate cervical cancer screening. And the third measure is not a preventive measure. This is a measure that represents the percentage of population who are receiving appropriate treatment. In this case, it refers to how many people with a diagnosis of diabetes receive A1C testing at least once during the year, and you can see the numbers right there. We are not going to go through more of this interactive report, but I invite you to explore it. Look at your county, look at your DOI, and make sure to know. And I want to make sure that you know that you are going to see a lot of information here. You see, like the access measure, for example, the adult children and adolescent access measure is presented with only 1%, but we also have further age breakdowns that are available for you to download if you are interested in the data from your county, and if you are particularly interested in that measure. One thing also that I missed to mention is that the cost that is represented in the interactive report is risk adjusted. That means that we are comparing, in a way, apples to apples. We are considering the age, the gender, and the comorbidities of the population to present the cost. But you can also access the non-adjusted cost if you request from us the Excel files that are behind this tableau display. So if we can go back to the presentation, and if you have any questions in the meantime, feel free to.
Yeah, we do. We actually have some questions, Maria.
Oh, really? Okay.
There was a question regarding what the total cost represents in these categories. And the question was, does it include the patient responsibility? And the answer is yes. So it is total, anything, the inpatient, outpatient, professional, and pharmacy under total cost here, which it should be indented so that it relates to this. So we apologize, something happened with our Tableau report. But that does include the health plan and the patient. So it is the allowed amount and includes copays, coinsurance, and deductible. Under the patient only cost, that truly is just the patient portion that was indicated on the claim. So that's the coinsurance, copay, and deductible just for the patients only. There's another question that I'll turn to you, Maria. The question is from Wendy. Does the access to care child measure include any provider such as urgent care, or is it limited to an attributed primary care provider?
It is limited to an attributed primary care provider, and we are the primary care provider definition that we're using does not include urgent care. And then there's another question from chat, right?
Yes.
About
yeah.
And the orange box is the rate, the paid amount for the selection in the filters. So the 56.6% would be for Adams County 2018 commercial payers. Well, if that's the, I don't know if that's the right percent, but the orange highlight is the selection you have in your filters, either by your county, your payer, your year, all those things. And then there is another question, right?
Yeah.
Provide the community with the data and the lower rates that we would like to see. Well, what we see is like the larger trends. So we are looking at the state level mostly and rural, urban. And we're gonna look, if we go back to the slides that we're gonna show, we can show you what these highlights that in the findings, but I think that we have one more question. Okay, well, that is a reminder where you can request the underlying data. And if you request the underlying data and get all the files and have questions about how to best use them, please reach out and we are happy to work with you so you can make the best use of this information. I think that's one thing that I always want to say. We are like the most happy when this is useful, you can use it, and you let us know what else will be useful for your communities. So these are some highlights, and probably I'm going to touch in the question from Jacqueline. We just look at the data at the state level and from 2013 to 2017. And we are doing 2017 only for two reasons. I didn't mention that, I missed that. We receive data from all the payers, commercial payers and Medicaid every month, but we have a different calendar for Medicare fee-for-service. So we don't have all payers data for 2019, for example, because Medicare fee-for-service is always 1 year behind. And then they are 2 years behind with data that is associated to pharmacy, which is why we cannot compare cost, considering all the things that go into total cost of care for all the payers for 2018 and further. But we are providing the information as recent and as available for all of you, considering all the payers. What we saw in terms of cost at the state level is that it increased 14% in these 4 years. And I know you are all familiar with healthcare, so this is not surprising, unfortunately. Then the measures that are behind are related to healthcare use, and there we saw that there was a decrease in healthcare users per 1,000, which is the use that we mentioned we like, because it's people who went to the doctor for a preventive visit or because they had something minor only, and that use decreased. The non-users seem to increase a little, but really that's not even significant. The ER use also increased, which is not good. It's not good news that more people are accessing emergency use. We don't know yet if this is like emergency room emergency room utilization that should have been avoided or not. We don't know that. We're gonna know in the next set of measures that we're gonna present, and we're gonna talk a little more later. But one thing that I want to mention about the emergency room utilization is that even when for the state as a whole and for all the payers increased, for Medicaid, the emergency room use decreased, and decreased about 12% in the years that we are evaluating in this report. And I just want to make sure that everybody knows that, because Medicaid is one of the most important payers in the state. They serve a population that we should all care very much, and they are improving in many measures, and this is one. Next one, please. So these are the access to care measures, and probably this is for Jacqueline. We are seeing increase in access to care for adults, and unfortunately decrease in access to care for children and adolescents. This is the period from 2013 to 2019, but we can look by county, and we can look also by payer for year by year, Jacqueline, if we look at the data, whether we download the data or we go through all the slices in the interactive tableau. So if that's of interest for you, and just let us know, and we can share that data with you. In terms of quality, all seems good news. All the measures, the 2 preventive measures and the diabetes A1C testing have increased in this time period. And as you know also, this is a time period where a lot of initiatives have taken place to measure and improve quality of care in the state. So that's reflected in those measures, and yes, probably it will continue.
Maria, I'm going to jump in real quick, because there was a question from Jacob about how we establish consensus on defining quality metrics, whether we consulted with other APCDs or what that decision-making process was.
Sure. Yeah, thank you, Jacob. We're using nationally endorsed measures. We are using the NQF measures, and we are using HEDIS to produce the measures that we can produce with claims data. So I would say the first slice is what are the measures that we can produce with claims data, because not all the quality metrics can be produced with claims data. Like, for example, there is another measure for diabetes, which is how well controlled diabetes is, and that measure uses the value of your A1C, the test that we are mentioning here. Unfortunately, we don't have that data as part of claims data. We know if you got the test because it was paid, but we don't know the value of the test, so we cannot measure that. There are many other measures that include those type of values that we don't have in claims data. So that would be the first cause. What are the measures that are feasible to produce with claims data? Once we have that, we actually have a plan of measures, and we have been producing different measures as we go. We decided that one of the measures that we can produce, because they are important to keep the population healthy, are preventive measures, and they have been our priority. We only have 2 so far. We're going to have more very soon. And diabetes, because diabetes is a very common disease, and having diabetes well care not only improves life and quality of life for many, but also decreases cost for the healthcare system as a whole. That's how we decided this. And we have a formal advisory process through our advisory committee that we can talk a little more about that. But over time, also we have with Carrie and the whole team, we have established a much more systematic way of consulting with community stakeholders and with our Colorado Advisory Committee, which represents several segments of healthcare, of the healthcare in the state, to see what is more relevant and what is more needed to know in the state of Colorado. And yeah, that was a long answer. Sorry about that. But we can keep talking. And there is another question about.
I think I addressed it. Yeah.
Is there okay?
Yeah,
Okay,
trend information isn't currently available. We'll be adding that to the next iteration where we'll have percent change from the previous year. So that'll be in the upcoming.
Yeah, but and in the current version, yeah, you are correct. It requires to download the data. So just to close, because I went a little too long, sorry. These are the new measures that are coming up in the fall 2021. And we, as I mentioned, we did a much more systematic and formal way to ask a variety of stakeholders about what were the measures that were more important for us to produce. We're going to produce well-child visits in the first 15 months of life, then 3 to 6, and adolescents well-care visits, as I mentioned, because we want to inform more about preventive care. As you all know, mental health and issues with mental health have been a focus in the state of Colorado for a while. So we are going to have the follow-up after emergency department visits for mental illness that has two measures, two sub-measures, and it is if people follow up within 7 days or people follow up within 30 days after a visit to the emergency room. And we're going to have a potentially avoidable ED visits measure. So in this measure, we're going to show who's using emergency room for things who could have been avoided, and who's using emergency room for, like let's say, true emergencies. And that's an important measure also to produce. And then for first time also, the percentage of children with at least one dental service within the reporting year. And I thank you everybody for your questions. We have one more. Sorry, I am just looking at the clock, and I think we've always, as you know, many things go into healthcare. One thing is that you have healthcare coverage, yeah, but do you have transportation? Do you speak the language of the doctors? Do you have a job that allows you to go to see the doctor or plan ahead? Like, can you call with a month in advance, because that's about what it takes to make an appointment, to make a well-visit appointment? Can you call in advance and you have the control over your schedule to do that? There are many factors that weigh into how you use healthcare and the consequences of that use or lack of use. And we know that, and that is one of many of the factors that contribute to inequitable health outcomes in the population. We have geocoded the Colorado APCD at the member level and at the provider level. What that means is that every person represented in the APCD can be linked to a census tract, which is the unit that the census uses to provide information for race, ethnicity, and socioeconomic position indicators like education, income, value of your home, housing characteristics, like if you live in a crowded space, do you live in a space that lacks some basic services, do you have access to transportation? That's information that we'll be using also to provide some light into why the distribution of healthcare indicators may vary, and to start looking at ways of addressing specific populations. And I think I'm going to stop there because we are running out of time. Thank you everyone for your questions.
Thank you, Maria. I'm going to turn it over to Tim now. We're going to switch gears a little bit to low value care. Pick it away, Tim.
Sure. So I'm going to walk through a recent analysis we did measuring low value care. So low value care is defined as care where the potential harm or cost is greater than the benefit to a patient. So back in 2012, the American Board of Internal Medicine Foundation launched what's called the Choosing Wisely campaign asking medical specialty societies to identify tests or procedures commonly used in their fields whose necessity should be questioned. Today, there are more than 550 of these Choosing Wisely guidelines. Most of the measures we analyzed for this project were derived from Choosing Wisely, while a few are from other organizations like the U.S. Preventative Services Task Force. This analysis then looks at 48 of these measures that can be determined using claims data. Also, a survey of physicians suggests that several factors contribute to the delivery of low-value care. These include things like defensive medicine due to fear of malpractice, the perception that patients want or expect diagnostic tests or medication, lack of information regarding a patient's medical history or inadequate time to spend with the patient, and finally, financial incentives or financial conflicts of interest. A 2019 study published in the Journal of American Medical Association estimated that 25% of healthcare spending, approximately $935 billion, is wasteful, and much of this waste is due to low-value care. Therefore, a reduction of low-value care is appealing because it can lead to both cost savings and improvements to quality of care. All right, so for our analysis, HCPUF originally requested this report and engaged Milliman to apply what's called their MedInsight Health Waste Calculator software on the APCD claims data. And from the results from this calculator, we present the overall frequency and costs of low-value care in Colorado by type of insurance and DOI region, as well as a subset of these 48 measures that account for a majority of the spending of low-value care from 2015 through 2017. Right, next slide. So there are a few key methodological points to understand about the analysis of this data. First is that only patients with sufficient claim history to be able to determine low-value care are included. Next is that these 48 measures have varying degrees of patient harm, ranging from low harm, which would be like routine general health checks, to a high degree of harm, which would be prescribing opioids for acute back pain. And then there are 3 degrees of wastefulness, from necessary care to likely wasteful care and wasteful care. And for our purposes, we grouped likely wasteful and wasteful into what's considered low-value care. And then the costs of these low-value services are calculated from the allowed amounts on the line of the claim that contains the low-value service. And then finally, these rates are based only on patients who have received at least one of the 48 measured services. For example, what we're calling the low-value index is the count of low-value services divided by the count of all measured services. And this is true for analyses on the member level and the cost level as well. Right, next slide. So now when we're looking at some of the results, in Colorado, spending for these services related to the 48 measures was $1.3 billion in 2017, which is roughly 6.4% of all medical expenditures for the state. About $140 million of this, which is more than 10% of the total, was spent on low-value care. The volume of low-value care services as a percentage of all services examined, the low-value index, was more than 35% in 2017. We also see that the trend in spending for low-value care decreased from 2015 to 2017, but the low-value index was somewhat stable. This would indicate that the types of low-value care shifted from higher to lower cost services. And then when we look at the impact to Coloradans, we see that of the 4.1 million individuals in the APCD, 1.36 million received at least one of the 48 services. And of these people, 53% of them received at least one low-value care service. And then here are the top 13 services that account for 81% of the total low-value care spending. These are shown here in descending order of spending. Now, some would argue that low-value care measures should be prioritized based on the volume of services rather than the cost of the services. We chose to go the cost method because by going by volume, it would replace some of these methods here with a high or medium degree of harm with services that had a low degree of harm. Also, a prioritization by volume would show a substantially smaller percentage of the total low-value care spending. Thus, prioritizing these measures on the cost shows a greater impact on both costs and quality of care. All right, now if we look at the results by insurance type, we see that commercial insurance and Medicaid account for a larger share of the $140 million in low-value services than Medicare and Medicare Advantage in 2017. Medicaid has a higher percentage of spending for low-value care services than commercial, even though it has a similar volume of measured services and a low-value index. This would indicate that the cost per low-value service is higher for Medicaid. And then although the low-value index was similar for commercial and Medicaid than it was for Medicare or Medicare Advantage, when we look at the utilization on a population basis, commercial and Medicaid have lower utilization per 1,000 members. Medicare has the highest utilization per 1,000. These lower population-based utilization results for commercial and Medicaid were observed because of higher volumes of low-value services were spread over a larger member population. By contrast, the higher utilization for Medicare means that low-value services are concentrated in a smaller population. And this raises questions about whether these services are concentrated in a smaller physician population as well. And then when we look at the results by regions throughout the state, we see that spending for low-value services is highest in Pueblo at 15.9%, which is significantly higher than the statewide 10.3%. See that the percentage of spending for the East region, for Grand Junction and Greeley, is also much higher than that 10.3% statewide figure. And then for the low-value index, Pueblo is once again the highest, but for other regions, we see that the index is also very high. Now, finally, it is important to note that the measurement of low-value care is not an exact science. Patient care is complex, and there are many instances where care that is flagged as low value may actually be appropriate when discussed between a patient and a physician. Also, there is not 100% agreement that all of the measures, the 48 measures that we analyze here, should be considered low value care. The main example of this is the routine annual checkups measure. The Choosing Wisely guidelines argue that a healthy asymptomatic adult without a chronic medical condition or mental health condition does not need a routine annual physical. However, many others would argue that establishing a patient-provider personal relationship may be beneficial for many other reasons. However, it is still important to identify care where the potential harm or cost is greater than the benefit to the patient and to minimize that as much as possible. All right, with that being said, we have used this data to create some very cool interactive reports, which Emma is going to walk us through now.
Thanks, Tim. All right, so I am going to quickly have us walk through a currently available interactive report that you can see is on our website. You actually get to this page in a very similar way as our community dashboard, public data, focus areas, low value care. This public version we have on our website highlights the volume and the costs associated with low value care at both the statewide level and at the Division of Insurance region level. And it allows you to do a lot of comparisons amongst these geographical groupings. So you can see from the tabs at the top that this report is broken into 3 distinct sections: an exploration of costs associated with low value care, the volume of low value care services, and then the number of unique lives receiving at least one low value service during this report timeframe. And each dashboard does have a very similar layout and similar sections. So I'm mostly going to go through this cost summary, and then we'll just show the last 2. They're very similar. So this first section, the cost summary, right away at the top, we can see what do statewide numbers look like in terms of low value care costs. You can see what that raw dollar amount is, how much we're spending on low value care. And if you hover over it, you can see some more fine-grained detail. What does that look like year to year? And how does it compare to necessary care costs for these services? Hovering over the metrics or the charts to get more details is pretty consistent throughout the report. So always hover, get those fine-grained details. You can also see the percent of spending on these services that was considered low value. Again, hover, see some more details, see the trends over time. I'll also point out that the info icon throughout these dashboards, if you hover, gives just a little bit of information on how we define that metric. So once you get a statewide summary at the top, then we can go into comparing different geographical groupings, which here we're highlighting the Division of Insurance regions. So the map to the left, you can see that range in the percent of low value spending by region. And if you select a region that you're particularly interested in, it will highlight that region throughout the rest of this section. So we just selected Grand Junction, and you can see on the bar chart to the right of it, now we've highlighted Grand Junction, and you can see where that ranks amongst all of the regions in terms of percent low value spending. And then the raw dollar amount in low value spending by year, that line chart or area chart below, you can compare the region you've selected, Grand Junction, to what statewide looks like. And you can see how those trends might differ from the geographic regions to statewide. Again, hover to get those trends over time. And then same with the percent low value spending, comparing statewide to a specific region that you're interested in, and hover to get some more details. The last section on each dashboard is breaking down by specific service types. So here for cost, we presented the top services in terms of total low value spending on that service. And then you can see the raw dollars spent for low value services and the percent of all spending on that service that was low value or considered low value. We've also color-coded this by the potential risk of harm to the patient. So the yellow and the red are the really concerning procedures or services that we're looking at. If you want to dig in even more to one service that you're particularly interested in, you can select it on this chart here. So we selected 2 or more antipsychotic medications. Everything else throughout the dashboard is now filtered and updated based on that selection. Everything we're looking at here is now just the service, the 2 or more antipsychotic medications. So you can really start to get more fine-grained details on specific services and what the costs and trends look like for that service across the state and DOI regions. Like I mentioned, the other 2 dashboards look very, very similar. You start with that statewide summary. What does it look like across the state? Comparing the geographic groupings, the Division of Insurance regions to statewide. And then lastly, a breakdown by the service level. As Carrie was just toggling through, The one difference with these last two dashboards is you can toggle between the different payer types if you just want to look at commercial or Medicaid, or you can look at all of them at once, just like the first dashboard is. So I will say that we are continually collecting feedback on these reports. So we definitely want to hear how this is useful to people, how it might be used, who might use it, or potential ideas for iterations of these reports in the future. So we definitely welcome that feedback as you guys are playing around with the interactive portion. And then I think we can go back to the slides, Carrie, if you don't mind. And then I just want to talk about one other version of an interactive low value care report that we do have available, specifically geared towards employers or groups of employers. For this report, like instead of showing a statewide summary, an employer will get a summary of their low value costs and volume. And then they can compare their data to a county of their choosing, a division of insurance region of their choosing, and statewide, as always. The one caveat is a lot of employers are just too small, insufficient volume of low value care services to produce the reports. So in that case, we have produced a version that really highlights county level differences for low value costs and services, which is a pretty good proxy if you're an employer or a different stakeholder who wants to see what's happening in your area and comparing across the state. And we really hope, armed with this information, employers can help to educate their employees on what low value services are occurring very frequently or that they may run into, and hopefully helping to promote value-based benefit design. And just with our public report, we're definitely looking for feedback. We want to expand this information to get it out to other types of stakeholders in the future. So we're always looking for feedback and interested in how people are using these reports.
Thank you, Emma. Appreciate you and Tim going through that. Excellent stuff. As noted in the chat box, we do have underlying data available for this report too. So if you are interested in receiving that in an Excel file, please fill out that little Google form. It's also on the website if you don't have a chance to do it now. I'm happy to share that underlying data with you guys so you can play around with it. We did have a question about from Megan, which is an excellent question. Do you anticipate services that fall into the category of low value that they will change in the wake of the COVID pandemic?
Yeah, I can take that. So Milliman regularly updates their health waste calculator. The measures that we have here are from version 7.1, but I know that they're in contact with physician groups and the Choosing Wisely guidelines to update their measures, add new measures, subtract measures. So yeah, I would anticipate that what has happened in the past year and a half will be incorporated into an updated version of the health waste calculator.
And I think it's good to a good segue. I don't think we really talked much about the update. So obviously the data right now only goes through 2017. Tim's in the process of submitting a new file, a data set to Milliman to make an update to this data. And hopefully we'll have, I believe we're trying to go through 2020. So that will, I think we're really excited to see. Anecdotally, we're hearing at a national level that low value care dropped in 2020. We don't know that for Colorado. We can assume since patients weren't really getting access to care the way that they used to, utilization was down in general, that perhaps low value care also was minimized at the same time. So stay tuned. We're in the process of getting the data there. Then Milliman goes through their process. We get it back, do all of the QC and stuff. So it'll be a little bit of time between now and when we actually have that new data released. But stay tuned for some updates through 2020, which will be interesting to see. I will go to the next Yeah, please feel free to ask more questions. We want always to hear from you guys. So reach out to us if you have things you think about, not even necessarily related to these reports, but other reports that we may have on our website. We'd love for you to connect with us on Facebook, LinkedIn, and Twitter, where we try to stay very active on social media. And again, a reminder that this will be recorded and posted on our event resources page. We do have another webinar coming up in August. It's August 19th. And it is focused on efforts to transform the way care is delivered and paid for. We'll be talking about the Medicare reference-based price report that's based on the RAND data that many of you probably have seen, but we have some different views and enhancements to that we've done for Colorado stakeholders, and then also data that we are providing to support employer purchasing alliances across the state. So beyond that, we are looking for topics. So if anybody has suggestions on other topics that you guys would like us to focus on, we would love to take that feedback. But otherwise, I think I'm not seeing any other questions. If anyone has one, this is the chance to chat that in to the chat box. Otherwise, we'll give you guys 4 minutes of your precious day back today. So thank you all for joining us. Thank you to our presenters. Appreciate everybody for being here, and have a great day. Thanks, everyone.
Thank you.